Mr. Chairman, ladies and gentlemen, thank you very much for the invitation to give a lecture about phase-adapted rehabilitation in patients with SARS-CoV-2 infection. I am very happy to talk about this point because it is a very important clinical issue at this time in Germany, but in many other countries too. And the entrance slide here shows the webpage of our department, and it says, welcome to our department, and you see the small tag that is a hint that we established a COVID rehab service here in my department, so that we have some experience also here with patients with long COVID. Just to give you an overview, what I'm going to show you in this lecture. First, I will introduce a little bit the definition and the phase model for health-related rehabilitation and the service types, because this is a very important basis to structure rehabilitation also for patients with COVID in the acute, in the post-acute, and in the long-term phase. And this is the second part of my lecture. And in the end, I will give a short outlook about the need of implementation of rehabilitation services and some scientific perspectives. Now about health-related rehabilitation. We have a definition of rehabilitation. However, the definition is, well, more or less homogeneous, but with some differences. On the one hand, and this is mainly defined by the World Health Organization, rehabilitation is defined as interventions, a set of interventions, or sometimes it's a set of measures to reduce disability and to optimize functioning. This is for those individuals who have health conditions and experiencing disability and to interact with the environment. Our group defined rehabilitation as a health strategy, which is based on the ICF model as written here. And the goal is very clear and very similar with the goal of the rehab definition of the WHO, which is to achieve and maintain optimal functioning in interaction with the environment. And both definitions are targeting the same. The one is more from the health strategy perspective, the other one is from the intervention perspective. So in the end, it is about participation and we need the services for that. And what is very important to look how rehabilitation should be implemented in health systems. And of course, rehabilitation, if it is a health strategy, but also if we look at it as an intervention, needs to be implemented in all phases of healthcare. So we have to start rehabilitation already in the hospital, and even in intensive care units, we should start with some rehabilitation interventions. Post-acute phase is very important for the rehabilitation, and of course then the long-term rehabilitation needs to be established, and this should be done closely to the living places, the community where the patients live. So in the end, for chronic diseases, it will be a lifelong approach, and we need to start with it, and I will show you later about the scientific background of this already in the very acute phase. We nowadays also add a so-called prehabilitation. So in patients where we know that we need surgery soon or any other intervention, we can start with a rehabilitation training already before the admission to the hospital. We have a German phase model, which is here shown in the lower part with phases A, B, C, D, and E, F. So there are different phase models, but almost they say the same, that we need these continuous rehabilitation services. What we, of course, also need, we have to think about what type of rehabilitation will be implemented in the primary healthcare level, in the secondary and at the third tertiary level of healthcare, and of course the acute rehabilitation, which is a specific ward or can also be done by mobile teams within the hospital. This is mainly in the tertiary level hospitals. For the secondary level, we have post-acute rehabilitation, which is after discharge from the wards or after discharge from the intensive care unit. This can be done in an inpatient, but also in an outpatient setting, depending on the structure. And of course, for the primary healthcare level, the task is to have community-based rehabilitation services or rehabilitation services delivered in the community, but they are also specialized. So those doctors and therapists who deliver this kind of rehabilitation also need special training. We described these types of rehabilitation services in the paper that is mentioned here in Journal Rehabilitation Medicine 2018. And as you can read here, for instance, for acute rehabilitation, that these services are delivered in hospitals at the secondary, mainly tertiary level. The target group is described, the services are described, what type of treatments are included here, and the goal also is described. And we have the same descriptions for the post-acute and the long-term rehabilitation. So if you're interested to go more into detail, you can look it up in this paper. What's also important that the World Health Organization has published recommendations how to implement rehabilitation health systems. I cannot go into the details with all of it, but I just wanted to show you one of these recommendations is that rehabilitation should be linked or integrated in the health system. The second one is that we should ensure that hospitals with complex cases, so tertiary, but also some of secondary hospitals, should have rehabilitation units. So this is very important, and here in Hanover, for instance, we have it even at the academic level. It should be clear that rehabilitation services, as I have shown it to you, should be implemented in the different phases, and it is also recommended that rehabilitation services should be done by well-trained workforce. So we need to think about the training of the workforce. Now, I would like to come more concrete to the rehabilitation in patients with COVID-19. And this is, of course, related to the phases of the disease. And we learned from the observation and some scientific studies that we have two acute phases in the disease. The one is, of course, the acute airway infection, which is a pneumonia, but all the structures of the lung is severely affected. But then, after a few days, it comes to a hyperimmune reaction. Some people describe it as an immune storm, which also causes symptoms and also may have lethal consequences. After these phases, if the patient survives, in the post-acute phase, the recovery will take some time. And of course, we have sequelae following the intensive care or the immobilization, which affects almost all body structures. Of course, in this case, lung function is in the center, but also cardiac function, muscle weakness, coordination issues, and many things after immobilization may occur. And we need to take care, even in the post-acute phase, in order to help the patients to regain the functions they need. And what we also see now more and more, and the estimate is that this will be in around 10%, but I feel it's even more, 10% of the patients with COVID. And interestingly, this is not only in patients with severe causes, severe symptoms in the acute phase, but also in mild COVID patients, we see this kind of symptoms. I will come back to the symptoms later. But in the so-called long COVID, I think we must differentiate two types. The one is the prolonged acute symptoms that I already described for the post-acute phase, but we also can observe new symptoms. There are multiple symptoms, and one of the most predominant symptoms is fatigue. There are mental symptoms, depression, for instance. We have alterations of the nervous system, which are seen as coordination, but also memory functions are affected, and many other symptoms can occur. And there is a nice paper here in the American Journal that shows the multiple symptoms, and they start, as I just did, with fatigue, reduced energy, depressive symptoms, deep sleep disturbance, then concentration and memory functions, smell and taste is affected, which also is part of the nervous system, and some patients develop generalized body pain. We have alterations of coordinations, muscle weakness, respiratory insufficiency, cardiovascular insufficiency, and also thromboembolic events that are not that frequent as we suspected in the early phase. Some gastrointestinal symptoms, some skin symptoms, and also the restriction in the end in performance, unfitness to work, so that many of our patients in our departments, around 50% of the patients we see are not fit for work anymore. We ourselves did a study in Bavaria, here in Germany, where we checked persons that had only mild or moderate COVID symptoms. So those patients have not been admitted to a hospital. They could stay at home. And you see, even in this group of patients, after 3 months, we see in 37% fatigue, in 28% chronic pain, 26% respiratory problems or sleeping problems. So you see that even in this group of moderate and mild, the long COVID may occur, and it is a strong indication for long-term rehabilitation treatment. You know that the pathomechanism of the long COVID has not been elucidated up to now, so there are some theories. But one thing I think is very striking or very obvious, that the symptoms are quite similar to the so-called cancer-related fatigue. The cancer-related fatigue is well defined, and here you see a graph of symptoms of patients with after different types of cancer, and you see here tiredness, weakness, pain, lack of appetite, dyspnea are the main symptoms, which is very much the same as we see in the long COVID symptoms. So it seems a more general response of the body to severe disease and severe immune effects. And you see here one of the theories how the long COVID may develop. And if you look at the tag in the middle, you see that on the one hand, we have the follow-up of the inflammation, which is not reduced totally. So this could be the persistence of virus, but also lymphopenia and autoimmune reactions in this case, but it also can be the consequence of tissue damage in the cardiac system, in the lung and in the nervous system. So we have maybe two mechanisms that are involved in that. I miss one aspect in this theory here, which is the autonomous regulation related to the autonomous nervous regulation, and we see this from the cancer-related fatigue. There is very well documented that the cancer and the cancer treatment may affect, on the one hand, the immune system, but also the HPA axis, which comes to some dysregulation, which is always in interaction with inflammation. And this could be one of the reasons for the fatigue, especially also for the sleep disturbances we see here. So we have multiple aspects of the pathophysiology, which is also important for our treatments, and especially for the rehab. I think the idea that the autonomous regulation is involved in that is very important, because many of our treatments intervene with that. And we also see in another fatigue syndrome, which is a fibromyalgia syndrome, that we can detect here some effects or some problems in the immune system, which is on the one hand here the interleukin 6 that has been measured by Nugraha and others, and we see this also for another mechanism, which is the MK2 mechanism within the cell. And you can see here the MK2. This is the tag here in the bottom. You can see that this also is a mechanism that induces some chronic immune and inflammatory phases. And this is the situation we have in the long COVID. What do we have to do in rehabilitation for the patients with COVID-19? And here in this graph, you see the same bottom line, that we have the rehabilitation in the acute phase, which is very important to apply their rehabilitation treatment. We do the early mobilization, which is very important for the long-term outcomes. We have a systematic approach in the post-acute phase. In Germany, we have the mechanisms that those patients can be transferred to rehab centers, inpatient rehab centers, after the acute rehabilitation, and then we have the long-term rehabilitation. I will go a little bit more into detail what kind of treatments we are recommending here. And for the acute phase, Dr. Liebel and some other authors here from Germany published a recommendation how these patients should be treated. And of course, in the foreground, it is the respiration therapy. This should be a combination of respiration therapy and mobilization, transfers even in the intensive care unit. Then we have the passive and the active breathing training, depending on the situation of the patients, which is on the one hand, the positioning to ease the lung function, but also drainage position, which is described here. And we also can use manual therapies to detonization, or with detonization techniques for the respiration system. And as soon as the patients are consciousness, we also can teach them to have exercise programs as soon as possible. Mobilization is very important to avoid the long-term issues of the immobilization, as I mentioned before. So this will be the transfers, assisted standing, and then walking with support can be applied as early as possible. And in our departments, the occupational therapists also try as soon as possible to train activities of daily living. Even in that phase, psychological management is of importance, so people can cope better with the disease, which is a really severe disease. What we also did for the symptom screening, we developed a questionnaire that is for the long COVID symptoms. And you see here some of the questions we added here. It's about sleep, it's about intestinal dysfunction, movement restrictions, and many other things that is based on ICF domains. And you can see here the patients can fill this in, and we use this as a screening. This questionnaire now is available also in English language, and there will be other translations. Maybe you also would like to have a translation into Chinese or Mandarin language. What we recommend for the treatment in the long-term phase is listed here. We published this in the American Journal of physical medicine and rehabilitation. And you see here that we, of course, use a multi-professional approach. We have physical and rehabilitation medicine physicians involved, but also physiotherapists, occupational therapists, psychotherapists, and some others. And of course, we need to be very clear about the individual symptoms, because the symptoms are different in different types of patients. So we need to have a focus on those symptoms that patients report to us. So the assessment is very important. And for the fatigue, for instance, and the reduced energy and drive, and even for the depressive symptoms, we know that medical training, aerobic training is very important, but we also can use hydrotherapy and other strategies to help the patients with that. Concentration, memory functions, we have specific training of memory function techniques in our occupational therapy department. Smell and taste, we can also train smell and taste in a systematic way. Body pain, it's on the one hand the muscular balancing we need there, but also the endurance training is important here. And last but not least, we should apply balance training to these patients. So even here we have a very clear program, and we are now also preparing a pathway with priorities. This is the second part of the recommendations. I will not go into the details, but all these symptoms we saw from the previous slide have some rehabilitation treatments that will help there. The basis is, of course, the experience. We do not have any prospective trials in this case, but this is due to the fact that this is a relative novel treatment. So in the end, I will give a little bit an outlook, and I will divide this in two parts. The one is about the health systems perspective. All those treatments we recommend here need, of course, a infrastructure. A service must be there, and we really must make sure and ensure that rehabilitation services is implemented in the hospitals. As I mentioned, this is the WHO recommendation that hospitals should have a rehabilitation department, but also to implement rehab aspects in the community health centers for the long-term care. We need to strengthen the rehabilitation workforce, which is on the one hand, of course, the physical and rehabilitation physicians, but also the therapists. I already mentioned physiotherapists, occupational therapists, speech and language therapists are very important. And we need to ensure that the access for rehabilitation is facilitated with an information system, but also we need the funding, of course, of the interventions. The Global Rehabilitation Alliance also wrote some recommendations with regard to that, and already published this in last year, and stressing that it is very important, even in the years of the pandemic, to strengthen rehabilitation. And one aspect I mentioned before, that it is important for COVID patients, but it's also important to ensure rehabilitation for patients with other health conditions in need, because there is a risk that rehabilitation will be in the background, and maybe some hospitals will treat acute rehab, acute COVID patients, and some other rehab interventions may be neglected. One point, and Dr. Nugaha will also report in this Congress here, that we also need to have a systematic approach to analyze how rehabilitation services are implemented. We have here a very structured, systematic way to do that, and we did this in Longhua district, and you will see the report on that, what we found out here. And this is also coming to some recommendations how to improve the service delivery, not only in the context of COVID, but also more general. There is a scientific aspect we need to take into account for the near future, and some studies already have been performed, I feel it is very important to elucidate the mechanisms of long COVID more in detail. And what I think one of the most important research questions here is the relation of the second phase, the immune phase, with the long-term sequelae. This should be correlated so that we can see if this is an immune mechanism. But also we look at the long-term patients, what kind of inflammatory signs they have, and maybe some biomediators similar to the chronic pain, and especially to elucidate the role of the HPH axis. We should identify risk factors to develop early prevention strategies for long COVID. We do not know what kind of patients they are and what are the risk factors. And of course, we need to develop and also evaluate the treatments. What we do here is to evaluate more in detail the physical medicine and rehabilitation interventions. But I also think, and I heard that in China, some traditional Chinese medicine approaches are already available, and maybe also there are some trials on that. We must think about drug treatments. Behavioral aspects are important here, and of course the social support. With regard to the interventions, I could show you some results from studies that use the same interventions in other fatigue-like syndromes. This is a trial here on exercise and multimodal treatment and a combined treatment in cancer-related fatigue. And you see that all these interventions are effective to reduce fatigue, but the combined treatment, the multimodal treatment, is more effective than the exercise alone. And you see a similar trial here, which is in the fibromyalgia syndrome. You see an exercise group, a cognitive behavioral group, and a combination group. And in all these groups, you see a reduction of the impact, the rehabilitation impact of fibromyalgia, but no effect in the treatment as usual, which is not a rehabilitation treatment. So you see other symptoms of fatigue can be treated successfully. For the long COVID, we do not have the clinical trials. And with that, I would like to end, and thank you very much for your attention, and good success for the ongoing Congress. Thank you very much.